Well, we're very excited to be here at Broadcasting House, and eHospice is very honoured to be in the presence of Dr. Atul Gawande, who's over here, I suppose, primarily to give the Wreath Lectures, which is fantastic in itself, but also to promote your new book, Being Mortal. You're known as a surgeon, and yet now writing seems to have become as much of your career as your surgery. And I was reading somewhere a wonderful story about how you discovered you'd been shortlisted for a National Book Award for an earlier book called Complications, just as you were about to go into surgery. And I was thinking, I'm rather glad I wasn't the person you were operating on at that time. And I heard about you, first of all, when my 13-year-old daughter had read Checklist, and she wasn't a great reader, but she couldn't put it down, and you had to read it. And then this comes out, Being Mortal, and it's focusing on what really matters in a very direct way, deals with end of life. And I can't think of a book that's had anything like this impact. You know, some years ago, the Tibetan Book of the Living and the Dying, and we have novels. We have novels like My Sister's Keeper or The Fault in Our Stars, but you go straight through the issues without the novels. Are you surprised by the popularity that this book in particular has had, given its subject matter, and what do you put that down to?
Yeah, I definitely am surprised. I'm delighted. I work really hard to try to make a story, and but put behind it, you know, here was a book about puzzling over this medicalization of the way we come to mortality, and interviewing a couple hundred patients and families about their experiences, and then doctors about what they do in these situations as well. And when I was late with the book, it was supposed to come out in spring last year, and when I had to tell the marketers that we're going to come out with it in the Christmas season, you can imagine how they felt about that. You know, a death book at Christmas? Who's going to give a death? And you know, this is my first bestseller here. My books have done well, but in the U.S. it is outselling any book by far that I've done. And here, the level of talk about it and engagement in the issue is incredibly gratifying. Furthermore, the real surprise to me is the spread of ages. You know, you talked about your daughter, that I'm finding about half of the audience who are coming to my lectures are under 40, and many are under 25. I think there's a couple things happening. Number one, a lot of people are connected to healthcare in one way or the other. There are nursing students, there are medical students, there are others who don't feel that this is very much a part of their curriculum and are very curious about these experiences. But then you also add to it that in our countries, you know, 80% of us die in an institution. It is behind curtains. It is invisible. My first time to see someone die was as a medical student. It was my first time I ever touched a dead body, let alone see what the aging process is really like. I didn't really experience that, except for the occasional visits for a family member in a facility. So I think that part of this is pulling back the curtain and asking you to come along with me as I go through my own learning process as well. I'm not purporting to tell you all of this from on high. You're the experts. And I visited people like you and I said, what should I be doing differently in my practice? And you gave me answers.
But it's very interesting, you know, you do present the facts, but it's not a book just about facts. You know, I've heard, I remember who it was, a lecturer said, if you want to have good care in older life, you need to have 3 daughters, or equivalent daughter-in-laws.
Right.
You know, I went back home and said to my 3 daughters, hey, good news. And to which they replied, well, you better start being kind to us now then. But it's not just you presenting the data about aging populations, multiple morbidities, and all the challenges. It's the way you use stories as well that I think is so powerful. You know, and I think the reason my daughter was captured by a Checklist was the power of the stories. And in this book, and you go one further, you're not just telling stories about other people, you are bearing your own soul, and that must have been quite a tough journey. And yet we live in a world where people want data and evidence. How do you see the interface? Your stories are a form of evidence, and I think they're the evidence that's getting through. Do you think that's part of the secret, the way you tell your stories?
You know, I think we've lost the art of the case study. You know, in the 19th century, 18th century writing about medicine, it was understood that the details of people's experiences and their efforts to solve problems as clinicians, that those imparted knowledge and was valued knowledge. And I really learned from Oliver Sacks and his careful phenomenology of the kinds of experiences people had with different kinds of strokes. I was reading him in the 1990s as I was going through medical school, and I think that influenced me to think that this was as valid a source of knowledge and truth as doing large-scale studies. Now, I've grown into my practice doing both. I run large-scale trials, trying to test out some of these ideas and data studies and so on. But I also then, in the course of this book, describe the stories of individual people as they go through the aging process, the battles they sometimes end up in with doctors and with family members. There are 3 core stories that are, I think, emblematic and important for a variety of reasons. I tell the story of my grandfather dying in a rural village in India at the age of 110, spending the last 20 years of his life needing dependent care, needing help, around the clock with needs, and yet getting to do it in his own home and remaining the head of the family and the head of the table. I describe my wife's grandmother dying around the same time, but in a nursing home in the United States, after 25 years of being independent and really loving her life, being the master of her own home by herself, but miserable about what happens when you start needing help. And then I describe my father's difficulties and in some ways successes, in some ways not, with a brain tumor. He himself a surgeon who gradually became quadriplegic and had enormous changes over a few years of his life. The reason I wanted to dive into those, in addition to my patient stories and the data and everything else, was that if I was going to describe what might be ways that we might treat death and aging and frailty differently and think about what our job is as doctors with unfixable problems, I needed to be able to reassure people that I was not describing something which was about giving up or taking away things from people that they really valued. So explaining what we did for my own father helped make clear that what I was struggling towards in this book was how we knew when to go for very aggressive care. And he got, a very radical surgical procedure. He got extensive radiation. But then when chemotherapy started to take away the things that were absolutely crucial to him at a minimum, being able to be interactive socially, being able to have some energy to be at home and get through the day, we stopped and changed to hospice and began to see that we were fighting to have good days, and he got more weeks of good days than we thought he'd get.
And I suspect it's that mixture between your scientific background, your personal stories and willingness to share them, and your ability as an extremely competent writer to get those messages across, that actually people feel secure listening to you and they don't feel overwhelmed by the stories because they know that there's something very solid underpinning this. One of the big changes I noticed when reading Checklist and moving to Being Mortal was Checklist was all about safety. If I'm being operated on, I want safety in capital letters everywhere. Being Mortal, you seem to reflect more interestingly on the tension between safety and freedom. And I love the story of the animals invading the nursing home and this whole idea of what is the balance between allowing someone to fall if that's what they want to do versus over-restraining them. That's going to be a huge challenge as we have aging populations and frailty as one of our biggest problems looking ahead. And
it was a surprise to me that this is where I found, I started out interested in what happens towards the end phase of life. The basic observation I learned from palliative care doctors, hospice physicians, and others was that medicine does not recognize that people have priorities besides just living longer. That the most reliable way to learn what people's priorities are is to ask them, and we don't ask them. And then once you realize we're not asking people about their priorities, you realize it's not just in those last few weeks of life. You realize we're not asking at the phases where, we are not so independent anymore. The way I'd put it is that I took for granted our priority in medicine is that we want to keep people healthy and independent, that is our number one priority. But then when people are no longer healthy and they can't be independent, we're kind of lost. Yeah. What is the goal? Yeah. What's the aim? And then we keep pretending, well, we're going to restore health. We're going to get you back to independence. My father, who was quadriplegic, the oncologist fell into the same trap. She said, you might be playing tennis again by the end of the summer. And it was so ridiculous. It was not in the offing at all. And that reflected to me the kind of thing I would say, because you're still caught in this idea that the only good life is a healthy and independent one. And what I discovered along the way was that In fact, there's that you can have a good life even when your health is limited, even when you may be dependent on other people, and that it's possible to have a life that is every bit as much valuable to you as when you were perfectly, without worry.
And that transition, is such a hard from when you're sort of constantly wanting more aggressive medicine in the hope of something through to maybe accepting that life needs to be different. And the bit of your book, perhaps beyond all others, that I will take away is you're looking at the word courage. And I think you decide the two parts to courage. One is to confront the reality of aging and sickness, but then I think, and really cleverly you go on and say, but the greater courage is then to act on the truth that you find, and to be guided, and to make the decision whether you want to be guided by your fears or your hopes.
Yes.
And the hopes might be about going back and doing another music lesson, as in one of your stories, or it may not be about wanting to, keep that aggressive treatment going. But for many people who aren't used to a medical world or a medical environment, and medicine increasingly giving the impression that it is going to do more and more in the future. We're printing body parts now. Where's it going to end? And there was a founder of one of our big internet companies recently saying he has no reason to believe he won't live forever, and he's going to invest money into making that happen. And yet there's a time when we need medicine to do less and less, or to do it differently. So what would your advice be to those who have no health background, who are coming to this and perhaps are facing doctors who have only got a curative vision, don't have any understanding of maybe that transition? Is there a checklist for those individuals themselves? And perhaps one of them is, what is it you're really wanting from the rest of your life?
Yeah, that question of what is it you're really wanting from the rest of your life is a really hard one until you distill it. I think it's a conversation that you have with friends, family members about what's your understanding? I think it's 4 questions. What is your understanding of your condition at this stage in time? So what do you understand about how poor your health is or how good your health is? Second, what are your fears and worries for the future? What are your goals if your health should worsen or if time is short? And then what are the outcomes that are unacceptable to you? And if you have some clarity around those things, then you can know that what you're fighting for is what your answers are. I'll give you an example. One colleague's father that I write about in the book, he, being asked those questions, said, if I can watch football on television and eat chocolate ice cream, that's going to be good enough for me. And this was from a professor. But he said, even if I can just have those bits of life, that is good enough. But take that away, and I don't want that. Well, I asked my father, I told him about this, and he said, no way that's good enough for me. He's a social creature. He was a surgeon. He's a control freak. He wanted more than that. He wanted to be able to have a social interaction with people. In fact, on hospice, he continued to have a dinner party once a week. He wanted to be able to still Skype with friends and family, still email to people. And as long as he could maintain connection to others, he was willing to sacrifice and fight for that. Yeah. Now, when he could no longer do that, then he said, I just want pain control. And he made me promise him I would give him enough pain medication, even if he wasn't alert, that he would not be in pain. Yeah. And fulfilling those wishes were difficult, trying to make it possible for him to walk that fine line where he's getting the therapy that allowed him to have more time, but then not sacrifice that chance to be with people and to connect and to do those things. And we walked that line, and ultimately he chose hospice. Even at the end, my mother would give him pain medication, then he would stop breathing for periods. And she became scared and would stop giving him pain medication. At one point even called an ambulance. Oh, yeah. And he woke up angry, at the situation. It's not easy.
It's not.
It's not easy, but you have clarity.
And we often hear people saying that you should be asking these questions in advance of you having to ask them. Has your experience made you reflect on this? Has it made you have conversations with your own family about what your preferences might be, advanced care planning, or do you think ultimately it's almost impossible to do until you're there in the rub?
I think a couple of things. Number one is that we always have the conversation too late, and so we need to move it up, and we should take advantage of those crises that come, when the first round of therapy doesn't work, or when an operation that has risk is coming. You have to talk about those things. But that said, there's no reason we can't discuss it in general, and I have had this discussion with my wife. What's funny is we come to completely different opinions about this. my view is, as long as I have, I could be a brain in a jar, and if it's connected to some sensory system that lets me communicate and talk, I would be, if I were Stephen Hawking, I'd still want to live. Yeah. If I were a body, however, that seemed healthy, but I'm not who I was anymore and I couldn't communicate, then let me go. Yeah. Don't prolong my life. My wife says that's stupid. She says, who cares if I'm not like who I am? If I look happy, that's good enough for me. Yeah. Just as long as I look like I experience joy on a regular basis. And, that's the further lesson, is that people change as time goes on. So you have to have these discussions as people's life changes. And I may become more like my wife's view of the world. My wife may become more like my view of the world. We may flip and switch.
For sure.
And it's and the fact that we never have this conversation, it's not surprising that we then fail people at that last stage. Yeah.
I'm aware that time is slightly running away with us.
Right, sorry.
The last question I want to ask you, we hope that this interview is going to be seen by frontline, professionals and volunteers working around the world, whether it's in wealthy countries or in slums of Bangladesh. And in particular, we have a very strong relationship with the One Hospice in Sierra Leone, who are doing remarkable work at the moment. And is there a message or something you would say to palliative care and hospice professionals? I don't know, I'm not sure a message of hope is a fair thing to ask, but something you would specifically want to say to them from your experience and from the stories you tell. I hope they're all going to buy the book or download it, because you can download it as well.
A couple things. One is thank you. I learned a lot from talking to your colleagues who helped me understand that just giving facts to patients, just being doctor informative, as I call it, telling people their risks and benefits and pros and cons and the prognosis, that they need more than that. They need someone who is willing to explain what the meaning is, whether you're worried about them or not worried, and whether you can ask the questions about what happens to them. So that knowledge of what you have learned how to make a skill out of the decision point with patients, just thank you. But second, I think, is to not be afraid of teaching us, the rest of your colleagues. I think the studies show that people who get early palliative care, that they choose less aggressive care, that they stop therapy, aggressive, often toxic therapy sooner, that they have less suffering at the end of life, but they also live longer. And that means that we have to be able to bring those skills more widely in the world. We're not going to do it by bringing everybody to a palliative care specialist. There aren't enough to go around. And in fact, these are basic skills all doctors should have. And so being able to become the people who monitor what happens in your own health system, in your own hospital or clinics, when patients come to this point, are the discussions happening? Being able to point out when those discussions aren't happening and being brave enough to go ahead and say, we're not having that, we're having these discussions too late. I'd be willing to teach and to coach your colleagues in how to do that. Mm-hmm. It's a different role. Most people just want to focus on taking care of their patients, but being willing to take care of your colleagues as we struggle through these points, I think that's the biggest opportunity and the biggest role that's out there for palliative care and hospice now.
A lot would agree. A lot of people talk about education and its importance. But I have to say a big thank you to you, not just for this interview, for your book. You feel in some ways almost like a prophet that's of the time, of the zeitgeist. And I think your stories are going to help lots of people navigate their own journeys. It will hopefully help people navigate their way into hospice when they should be there. And if I was still running a hospice, there would be times when I'd be taking that to families and say, well, as you're thinking about things, just read this. It might help you. And I think you will have your stories are going to have a huge impact in all sorts of unexpected ways. So thank you for today, and thank you for having the courage to share your stories, your personal stories, as well as your professional ones.
Thank you.
Very good. Thank you very much.
Thank you.